Good afternoon, everyone. Thank you for joining us. I know we still have some people that are signing in, but we're going to go ahead and get started. I'm Andrea Bonacci, Director of Healthcare Workforce Development with Adirondack Health Institute and overseeing the North Country Telehealth Partnership for AHI. This is a collaborative effort between AHI and Fort Drum Regional Health Planning Organization. Thank you again for joining us today. I'm going to go through a few brief updates before I hand it over to our presenters. Just some updates that we received from the state and CMS, and these updates will be included in detail in the meeting notes that will go out along with the presentation, which is being recorded. So from New York State Department of Health, the update is that DOH updated the New York State Medicaid telehealth manual on the telehealth webpage last month. So there's a change which I've included. It's Appendix A. It's a change log, and I've included a snapshot of it that will go out with the notes. But essentially, the message is many of the updates in the manual have been announced via the Medicaid update articles over the last several months. New York State DOH is attempting to update the telehealth manual every 6 months to include any policies announced via the Medicaid update. But the change log in 11 Appendix A is the change, and that's being included again in the notes. There were no updates from Office of Mental Health, OASAS, or OPWDD. A couple of updates from CMS, Center for Medicare and Medicaid Services. So the waivers of geographic and site of service requirements of the law have been extended through March 31st of 2025, as have the additions to the types of telehealth practitioners. The requirements for in-person services for behavioral health have also been delayed through March 31st of 2025. The other update is that CMS has not adopted the new CPT 98XXX codes for telehealth, and the 9944X codes for audio-only services are no longer recognized. Audio-only services should be reported with modifier -93. So again, all of this is going to be included with the meeting notes, so you have that information. And if you have questions, I can reach out to DOH and CMS for additional clarification. I am going to just jump ahead and share, as many of you have heard, Adirondack Health Institute and the North Country Telehealth Partnership was awarded funding through the Connect All Offices Digital Equity Technical Assistance Grant. I don't have any updates at this time, still in the early phases of contracting, but more updates will be available as this project moves along. And there were no additional updates from our partners at FDR HPO to share. There are some updates from the Connect All office, new funding opportunities that have been released. All of that information will be included with the meeting notes as well that I'll be sending out following the presentation today. And then in the agenda, I listed several updates and new information on research and articles, as well as upcoming telehealth webinars and events, conferences. So those are on the agenda, but they'll also be included in the notes. So please, refer to those for new education and information opportunities coming out. Next Learning Collaborative is going to be March 24th. And so we are looking for presenters. If anybody is interested in presenting on a telehealth related project, please reach out to me. And then today we have our presentation, Innovative Workforce Solutions, Telehealth-Enabled Care Models for Sustainability and Resilience. And I'm going to introduce both of our speakers. They're going to be, transitioning in the presentation. But first speaking is from Equum Medical, the Chief Medical Officer, Dr. Anisha Mathur. And then following, we have Christian Milaster from Ingenium Digital Health Advisors. So I will hand it over now to Dr. Mathur. And I'm going to be in the background. If anyone has any questions, pop them into the chat and I will answer them. questions and answers, typically we save for the end of the presentation. So if you have a question after the presentation, you can feel free to pop it into the chat, and then I will ask the question to the presenters. So, thank you. And Dr. Mathur, if you'd like to get started, please go ahead.
Thank you, Andrew. Would you mind just adjusting Dr. Mathur to make her a panelist? I think she came in as guest.
Oh, that's right.
Thank you.
Just a second. Here we go. Okay, so she should be a panelist now and should be able to unmute. Yes. Okay.
Perfect. Thank you so much. And sorry for that technical challenge. I'll be representing Dr. Corey Skurlock today. Unfortunately, we had a last minute emergency, but I'm so happy to be here and so honored to be part of this group. Dana's going to be helping me drive the deck forward if we could just get started. Great. So I think many of you may have seen the learning objectives already, but we're really going to talk about how we can create flexible patterns for care models within the telehealth platforms and use it to stabilize workforce, reduce burnout, and really expand coverage in terms of specialty access and other things. I'm really looking forward to just getting right into the content. Right, so a little about me, since many of you may not be familiar with me, my backstory. So I actually am from originally rural Southern Maryland, Charles County, St. Mary's County, and from a small town. I've lived in various cities after that in my medical training, but I think truly in general a Southern girl at heart. I'm triple board certified in infectious disease, internal medicine, and critical care. My critical care training was at the National Institute of Health, and I don't know if you're familiar with the phrase, but many people refer to the NIH as the House of Hope. It's a place with no limitations, no barriers to innovation or access, and that's starkly different what's actually happening around America. And really, what drove me to work with Dr. Skurlock here at Equum, he's the founder and CEO, and founded Equum in 2011. Together, we really share a passion for rural healthcare, bringing access to care, across the United States, and doing so in different platforms. I would say that just briefly about me, I've over 7 years of experience implementing telehealth programs, and we've partnered in over 140 hospitals ranging from California, New York, the Canadian border, Texas, and that's critical care coverage, but also other virtual support solutions. For me, what I'm most passionate about is transforming the rural and critical access space in terms of getting it access to care. I've launched programs in critical care, cardiology, infectious disease, nephrology, and pulmonary, and we work very close with our nursing and telemetry specialists to move innovative solutions into the inpatient setting and really redefine healthcare delivery. So without much further ado, I just want to move forward, but I do want to comment briefly about Corey, Dr. Skurlock's background, and what really inspired him to start Equum. He hails from a small area of Texas, and what he loved to sort of comment on is that in his area, there's 82 critical access hospitals within Texas, but one closes every quarter. And so, of course, the dense populations of Houston, San Antonio, El Paso have a lot of support services, but the rest of the population in that state has limited access to care. And so I think that's something that if we could move forward, Deanna, please, that's a problem that we see in other places where I'm from in Maryland, and of course across New York, across many other states. So how can we really bring access to care 24/7, regardless of geography, and prevent patients from leaving their home institutions and staying local? And while doing so, supporting the healthcare workers, both the nurses, the ER staff, hospitalists. And so to do that, we have to put in solutions that provide expertise to these complex medical decision-making when it comes to transfers. If you could go forward, please. So what are the challenges we have today? There are no two hospitals that are the same. I think we all recognize that, but there are a couple of challenges that we share. And there are things that we've learned in the pandemic that are still there, even though we think they're fixed, they're not. And I'm going to speak to that a little bit. We commonly describe these challenges as the 4 S's. The first one is space. What is the right type of space in a hospital setting? ER beds, ICU beds, inpatient beds. We also have challenges with stuff during the pandemic, PPE, ventilators, etc. Staff, But more importantly, the right type of staff poses challenges to hospitals. So I'm sure you've seen ER doctors doubling as ICU doctors or hospitalists working in an ICU setting. And while they may be very capable, it strains the system, which is the final S. What is the right system? Post-COVID, I think all of us recognize that a lot of things have gotten better, and we have caught up with at least the stuff component. We have the right protective gear, but what we have not solved for is the staffing crisis. There are still beds that are being misutilized or underutilized. We're boarding patients. And during the COVID period, a lot of new programs came up, but they're fragmented in their approach. They're not connecting the larger system from the ER all the way to discharge. And that's something I'm going to be talking heavily about, which is patient flow. How can we make one care continuum straight through the hospital system and through that patient's journey? That's really important to solving any of these problems listed here. And so these are just taking a moment to take in. These are probably the challenges that we all can relate to here on this call. If you could move forward, Deanna, please. This isn't a new metric. I'm sure many of you are familiar with the fact that 64,000 physician shortage is expected, but why? And I think there's many different ways to answer this question, but I think I'm going to be mainly focusing on the physician inpatient side. The US is growing in terms of its aging population. It's top heavy, and that could be true really throughout the world. We're living longer and we're using hospital resources at a faster rate. For example, when you turn 65, you're using a hospital 3.5 times the rate that you would when you're much younger, and that number continues to expand as we get older. This combined with the fact that older populations live in rural spaces. They don't live in urban settings, for a variety of reasons, cost of living, different social reasons. So if nothing else changed, whether it's new chemos, new surgeries, new other things, the aging population alone here in the US is going to increase hospital demand by 35% over the next decade. That's going to continue to strain the system even more. So hospitals really have to find a way to take care of these patients, bring the supply to meet the demand essentially, but what is the state of our current supply? And that's really where this slide speaks to sort of what is contributing to the loss of physicians. Are new doctors coming in? I know personally, in the infectious disease programs, there are spots that are unfilled. Not too many new programs are opening up. More doctors are retiring. And, coming from a generation where I speak to my colleagues, they don't really want to work nights. I think we have to find ways to reduce burnout and meet the expectations of a better work-life balance. And so all of these things contribute to burnout. But in this particular study, what they found most contributing to burnout is schedule. And doing tasks that are not clinical. So how can we use telehealth to delegate some of these tasks and offload our doctors so that they want to stay in healthcare? Night work being one of the most common signals for why somebody would want to leave healthcare and contributing to their burnout and personal and professional reasons. I think all of us can relate to that doing night shifts the next day can be brutal for your home and personal life. If we can move forward, please. Some specialties are impacted by this more than others. In fact, in this recent JACC paper where they looked at 3,000 counties of the US, half of them don't have a cardiologist. And if you look to the right side, you see this, lonely heart running on this empty rural road, really representing the, 80, 90 miles that patients and their families have to travel to go see a cardiologist. In the rural communities, 85% or almost all of them don't have a cardiologist, and yet those people have a 31% higher cardiovascular risk. They're sicker. On top of that, the distance alone, I think, adds to lack of follow-up, poor compliance, things like that, and ultimately contribute to lower life expectancy. Contrast that to counties where they have a cardiologist at the bottom. There's a lot of them. So dense areas like Manhattan, like Houston, like El Paso, there's a lot of cardiologists available. So how can we support the rural areas? A similar graphic to the right of infectious disease docs. I practice rural virtual infectious disease consults. I'm very well aware that there is just communities out there that don't have specialists. If we can move forward. So let's talk about that more, particularly in the rural market. I think that's near and dear to all of our hearts. I'm going to hit on some studies as well as some work of our own that really articulating how can we reverse this trend. What we see more often than not in the rural environment is that patients are being transferred out pretty frequently, and they're being transferred out for a number of reasons. Number one, that we find in our work and what this survey supports is there's lack of specialty services like we just talked about. And I'm not talking about, advanced cardiology or neurosurgery or really like, niche specialties. I'm talking about fundamental needs, cardiology, nephrology, infectious disease. And so really when patients leave, they're leaving for a specialist more often when they're leaving for a higher acuity need at a higher, bigger institution. The second more common reason for leaving was that the hospital sends them out. And you might say, well, why are you sending them out? Let's talk about that. And the reasons they transfer out may not be good, but it's something that really needs to be looked into. And then there, of course, are reasons for appropriate transfer. And it's something that really needs to be really examined on a local level. The other thing I'll mention is that the local institution, if they don't have a specialist, the local providers become the specialist, and that further contributes to burnout. I have personally seen, family medicine doctors having to double as the ICU doc while balancing clinic, or an ER doc that is really the ICU doc at night, and we'll talk about more. So can telehealth address these things? Access, reputation, support, absolutely yes. And it's an excellent quality tool too. So while you're doing that and bridging these gaps, you're also contributing back to the quality of care that's being provided. Next slide, please. All right, so this is something I love to share. It's so great that telehealth can reverse some of these problems, and we flip the narrative of how we do that, and let's keep patients local. It's a clinical impact, of course, but it's also an emotional one. Patients get to stay closer to their home and be local, and that drives financial benefit to the local institution. When you look at what hospital leaders are saying, they think that leakage is one of the primary reasons for their system breaking down and blocking them from reaching their financial goals. And yet they don't necessarily have a plan in place to reduce the leakage. And when asked, leakage is more of a problem than changing payment models. So we clearly know that this is a problem. And honestly, it's a problem in rural settings, but I've seen it being a problem in larger institutions alike. So what we need to do is that we have to have a right program, the right people, the right process, and look at the root cause of the leakage and then customize a solution for any local institution. So it could be maybe access to a nephrologist, or it could be access to a cardiologist. It could be a variety of things or all the things combined, but really it's about tailoring the needs to the local site. We'll look at that leakage data with you and come up with a plan. And it really doesn't take that many patients kept to generate return on investment to a service like this. And when I talk to hospital CEOs, I really share that last sort of quote, that it costs 90% less to retain a patient than attract a new one, because once you've lost that patient, you typically lose them for life. They go to the next institution, they get connected with their specialist and follow-up appointments, and they may even share with their loved ones the experience they've had. And so we disconnect them from sort of the continuity of care that we're able to provide locally. Next slide, please. All right, so I mentioned the word flow briefly in the talk, or you may have heard it in some of the things that are important to us as an organization. Patient flow is a central KPI to any telehealth program that wants to impact leakage and bring value back to a organization. When done right, it's a win-win for both the patient as well as the institution. So we want to get the right patient, the right care at the right place at the right time, and hopefully the answer to that is in their local environment. On the inpatient side, that journey starts right in the ER. So we put in programs in place right to the ER doorstep. And because that's where the triage is done, that's where that first decision to transfer a patient happens. If you want to have opportunity to make meaningful change, you have to hit them before the patient is decided to get transferred. And of course, if they have to transfer, then we also put in processes in place to support them while they're boarding. And I think it's, maybe it's near and dear to my heart, but so for example, if a patient has to leave, at least a consultant can continue to see them and virtually support them with early interventions that we know clinically translate into better outcomes. Early antibiotics, and not just any antibiotics, the right one, reducing complications, or maybe patients with questionable MIs, things like that. We have to get access to the specialist opinion, even if they have to go. On the flip side, once the decision is done, I think, and maybe the patient is able to stay, on the inpatient side, we've wire the system to support the entire hospital stay. So, have patients maybe get admitted by a virtual nurse to offload the bedside, or maybe virtual nursing helping with discharges so you can open up a bed faster, bringing the ICU doc to the ER, things that can help move that particular patient further along in the journey so that they can help sort of remove the bottlenecks that we commonly experience. It unlocks net capacity, and ultimately it's a win-win for everyone when they have access to care. And as providers, we know that the system is running smoothly. There's so much more conversation that could be had about that, but just sort of at a very high level. I think unloading the local doctors is sort of a bystander effect that happens when you focus on flow. They feel supported, less insular in their practice. All those things lead to less burnout, and making sure that we can get to the complex cases early. Next slide, please. If I think about the current process of healthcare, and there are two things going on. There's workforce redesign. There's a shortage of doctors. We just talked about that. There's also a shortage of staff in general. But then the delays in patient flow is the other key thing that we just spoke about. But virtual care is being woven into how we're taking care of patients. But really breaking that down a little bit further, I really want to think about sort of telehealth in three historic eras. The era before the pandemic, that's when we saw telehealth growing at an exceedingly fast rate, a 300% annual rate of growth for telehealth. The first tele-ICU is actually 25 years old. Tele-stroke programs have been around for a long time, and those were early adopters and did great for sort of boosting data, boosting the community's acceptance. Then the pandemic happened, and I think it helped with put a spotlight on telehealth in all venues, outpatient, inpatient, follow-ups, even people within the hospital using iPads to see cases within the ICU or connect them to loved ones. So while all of that was great, it also put hospitals into a panic buying period and putting up programs rushed without a lot of thought into the long-term sequelae. And hospitals face a lot of challenges. We just spoke about them. They said, oh my gosh, we need ICU beds, put up a tele-ICU, we need ER help, put in carts for ER staff to come in and see patients, similar for hospitalist shortages, help get virtual hospitals up and running. And there are some niche products that support those things, but now that we're in a post-pandemic phase, we need to think about all of these tele or virtual solutions working together for not only better outcomes, but for sustainability of the program. And so that's that bottom sort of section of talking about fragmented partnerships is really not the way to go. It's not for long-term success for a variety of reasons, which we can talk more about. If you could go to the next slide, please. So what we really need, and kind of what I'm alluding to, is this care continuum, connecting the care across the entire spectrum of a hospital organization. It's something that we take very personally, and making sure there's sort of this spectrum of services that connect from the ER door all the way to discharge, and even in the post-acute phase, making sure there's collaborative connections and strategies for reducing overcrowding, helping with transfers, helping with continuity of care, fill in staffing gaps, and protocolizing the care. That's something we haven't really talked about, but when you put in virtual solutions, you're also able to standardize the care delivery. It could be things like best practices for GI DVT prophylaxis, glucose control, CMS measures supporting sepsis, lactates, things like that we know are going to bring back not only value, but quality for the patients. And so offering sort of a single platform strategy is not really the long-term solution. Having one single vendor that can support all these different ways to tackle those problems on that very first slide is really the way that we support. I think it's also another way to bring in resource reallocation. So if you have a tele-nurse or a virtual nurse or a virtual physician looking at some of those core quality measures in a quiet, focused, office-like environment, it's so much easier in terms of delegating some of those clerical tasks that we know are contributing to burnout, and yet it has so much value: stroke initiatives, sepsis initiatives, etc., CHF, to name another. If we could go forward, please. So now we're going to just briefly talk about some of the published data on telehealth, reducing costs, retaining patients, how do we optimize labor costs, increase services, and then be competitive to our competing organizations. If we could move forward, Deanna, please. So this is a University of Mississippi study around tele-ER, in bringing it into the ER space. Pretty well known in the tele-literature environment. It looked at 14 hospitals in Mississippi. They were all critical access hospitals. And what they did was they compared it to 102 hospitals in Arkansas, Georgia, Mississippi, South Carolina, who were similar in size. They brought in a tele-ER cart into the ER and looked at their cost. And two things we can sort of see here on those two graphs. There's an unadjusted cost, and at the bottom shows their adjusted cost. What this researchers found was that when they put in a virtual ER service, they reduced their annual ER cost by about 31%. But what maybe strikes me the most as someone who implements programs is that none of the 14 hospitals where they put the tele-ER carts closed down. But 20 of the hospitals that didn't have the tele-ER did close, and all contributed that closure to financial reasons. And so while that's not sort of a study metric, there's plausible protective benefits of having a ER doc to help triage with this patients for all those reasons we spoke about. Helps with flow, faster care, maybe supports your colleagues to feel less alone in those busy shifts, and helps retain patients locally, providing revenue. Next slide, please. This is also a famous study in the telemedicine literature looking at the financial outcomes around tele-ICU, and this is out of UMass. UMass tele-ICU program is well established to be highly functional over the last 20 years. They've done various studies looking at length of stay, mortality, and found those to be beneficial. In fact, they report a 20% risk reduction in mortality when you implemented tele-ICU, and they also saw a 20% reduction in length of stay. And so all of those things were already part of their prior literature, but here they did something new. Here they combined their tele-ICU with a logistics center. And a logistics center is just a fancy way of saying air traffic control or bed management. Some places call it that. But it allows the tele-ICU doc to have full control over the aerial view of that patient flow and movement. So that means, reallocating beds. It means moving sick patients at the smaller institutions to higher level care when appropriate to do so only, which means that maybe sicker patients can actually stay at their local institutions if it's safe to do so. Things like that. It's actually things that us as an organization within Equum have replicated to match outcomes of this study. And so what they found was that when they added the tele-ICU to the logistics center, they brought back total revenue by over 600%, increasing their case margins. But more importantly, they also reduced the cost per case. And the reason that is because in addition to having this air traffic control, they were able to also standardize other processes across the system. They put in, I think, like 35 protocols within the implementation of this new study. And so that helps drive the cost per case down. And that's sort of the red line that you see there. And so here we are increasing revenue, reducing costs, and ultimately a win-win for patients because it helps load balance across the system. Next slide, please. This is an indirect way of really talking about flow on a practical level. This study of critical access CFOs, I'm not going to read all of it, but essentially the CFOs of these critical access hospitals all had a very positive opinion about telehealth and what it can offer to their local institutions. And many of, I know from our work here that we do at Equum, not every critical access hospital even has an ICU, but there are complex medical patients that our virtual team can help support even without sort of the walls of an ICU. And that just brings back this concept of equality regardless of geography. So what they found in this particular paper was that the tele-ICU avoids transfers, helps retain patients, helps reduce labor costs and provider recruiting. If you have a staff knowing that there's a backup doc, right at a push of a button away or at the call of a cart, they're happier at their job. They feel supported to bounce around ideas or to actually get consultative help. And it's cheaper than bringing in locums or cyclic staff. It's a more sustainable option is what they found. Next slide, please. This is looking at our own study, and I'll sort of set it up and tell you the backstory behind it because it's pretty busy. But this is a community hospital in a rural setting, and this hospital was acquired by one of the customers of Equum. Historically, this hospital, whenever they had a patient that was too sick, would be transferred out to other certain hospitals. And now those hospitals, post-acquisition, were competitors. And so what we did was we went in and we asked the ER, you know, what are these transfers for and why are they happening? When you ask the physicians why patients are leaving, a lot of times they have good reasons. The first one they said is that, well, the ICU or their step down high acuity area is a ghost town at night. They don't have the staff they need. You know, maybe then this is just sharing other examples. Maybe they don't have a respiratory therapist, or maybe the ER doc sort of doubles for backup emergencies at night, things like that. So it's a ghost town. The other thing is that, you know, the local ER doc at that institution would have to help support any sort of decompensating patients. And so now while they're fully capable and trained to do so, they're wearing another clinical hat, which takes them away from their ER patients. And they're like, we don't want to do that. And then the other thing is that the competing transfer center makes it very easy to accept patients. You make a phone call, they take them, and you're sort of, you know, your hands are done and you can go on to your next patient. And so we have to sort of tackle all these different things. And so the red line here is the competitor transferring patients out, and the green line represents retained patients. Oops, if you go back. So what we did was we hired their local high acuity area, brought carts to the ER, made a very seamless transition so that if there is a quote unquote high acuity case that would have potentially left, so that's where that admission decision support comes in. They would call the tele-physician who would see the patient right away, discuss the case, get connected to the actual patient. It's easier to retain a patient when they've already met their specialist and sort of heard about their care plan, and versus, you know, presenting it to them after the fact. And during that process, putting in our own orders, our own notes, really connecting with the bedside nurse so that he or she knows exactly what the plan is. So that takes away the ER doc stress from having to manage those critical patients. And so basically, other than basic procedures, which we couldn't do, we took care of those patients fully. And, you know, talked to families, had those difficult conversations, et cetera. And all of those small little details added up to the outcomes. Early interventions really do matter. And what you see in this slide, without sort of I could probably go on forever, but what we see is over the 2-year period, the cases retained went from 29 to 70%. It's a net, you know, 220 cases. So just for contribution margin purposes, if we're estimating 10K per case, that's about $2.2 million in contribution margin. That would easily pay for a service like this, but I think the bigger picture is that it's a win-win for ER, for the patient, for the hospital, and it really goes back to patient flow, early interventions, and really driving quality and financial viability of a program. Next slide, please. This is a different scenario that, you know, isn't really looking at, you know, retaining patients, but it is sort of looking at how we can offload the staff and do something similar at a much critical rules setting. So here we are, critical access hospital in the Northeast, as I mentioned, you know, sharing earlier that there's family medicine docs who run it along with the clinic busy work that they do, and they're staffing the hospital. So at night, a patient may be placed on observation for 23 hours, maybe waiting for triage, waiting for intervention, waiting for a transfer decision. And so they didn't really have the capital to invest in new services. They were falling below their average census to a key threshold and risked actually losing their critical access status, which would have triggered, you know, a ripple effect to their closure. And so similar to implementations, there's some commonality there, but the telecritical care team came in, ensured ED borders were seen and addressed quickly, reduced unnecessary transfers in that same admission decision support style. But also keep in mind that nighttime, where we know is that highest risk to patients, it's the time that no one really wants to be in the hospital. We can help with complex medical cases or regular sort of medical admission so that patients can continue in their journey and their flow. And then once the patient is admitted, the specialty service in this particular circumstance was ICU, continues to follow those cases. So it's not like it's a one and done, hey, we saw this patient. It's continuing to follow them and support the staff for the duration of their stay. This particular hospital was able to renew their critical access designation for 2 years as opposed to just 1. But more importantly, patient outcomes improved and they were happier to be supported locally if we could move forward. Another example of that more recently is launching virtual dialysis programs. This is a press release by one of our partners. There's a critical access institution that was transferring patients 2 hours away just for dialysis services. So through our critical care team and also our virtual nephrology team, we were able to implement virtual dialysis. In doing so, they've been able to keep patients from having to transfer. And as this is a smaller program, but I think it speaks to all our hearts in terms of what they value on the personal level is bringing back to that community, to that hospital. And we hope to do similar things at other institutions. For example, the next slide, this is a story of a recent project at another critical access site that was already using our critical care services. And they said, hey, we are losing patients for cardiac reasons. So we brought in our virtual cardiology team, put in processes in place to make sure we had the right resources, nursing staff, medications to keep those patients. Within 4 months of the program, we saw a 27% reduction in proportion of cardiology-related transfers, and also importantly, a 38% increase in cardiac-related admissions. And so I think this is just 4 months into the program, but I think it's just been growing so tremendously in terms of the patient satisfaction. The staff feel great about keeping those cases, and it continues to offer additional ways to support the local community with echoes, stress testing here locally. So a lot of wonderful things happening at that program. Next slide, please. I think to kind of close out sort of the big picture goals, reducing leakage translates to retaining revenue. Increasing access and expanding services and optimizing patient flow, I think, are the 3 big things that I'd love for everyone to take away from this. But really, how do you put action into any of these things? I think there are 3 things that I would probably say are the focus areas. First is infrastructure readiness. What foundation is already in place? High-speed internet, ability to support diagnostics tools or secure IT. What's interesting is you don't have to have complicated hardwired systems to run a tele-ICU program or specialty program. We've found at institutions, they may have leftover iPads. We just need a connection. In fact, it's the right people in the process. That technology is really an innocent bystander that helps us communicate, but isn't what makes or breaks a program. But we do need to fill that gap and prioritize how that's playing a role. And the goal is also about workflow integration. We don't want to rip and replace, but we do have to collaboratively develop protocols and work together with the staff, really investing in their vision and what KPIs they want to achieve, and then put in protocols with the technology to support the system and not disrupt it, and using communication as an efficiency tool, measuring outcomes, other things that we come up during the design phase. And the last one is data collection and program evaluation. And I think whether it's through a grant or a privately funded program, I think finding a way to monitor metrics is extremely important. So we can look at compliance to the program, what's the sustainability of it, having regular check-ins with stakeholders and champions. Having one key individual being a champion of the program has been one of the biggest yields of success in my experience. There's so many more things that I think we could be speaking about, but I'm really looking forward, if you could go to the next slide, please, Deanna, to hearing the next part of this presentation and how do we operationalize some of the things we've talked about today. If anyone is interested in learning more about me or the work that Equum does, please feel free to find me on LinkedIn. Thank you so much.
Thank you, Dr. Mathur. It was a very great overview. It's always exciting to hear things from a clinician's perspective, which I provide a little bit different perspective. So good afternoon, everybody. My name is Christian Milaster. I'm an engineer by training, originally from Germany. Fell into healthcare at the Mayo Clinic 25 years ago. I have another slide to introduce myself here, but very excited to be here. If you do have some questions, I think in this WebEx platform, there's a chat enabled, so post them in the chat. I'll be seeing if I can pull that up again, because after I shared my screen, everything else disappeared. But because we're a little bit pressed for time here, we have prepared a lot of good content, and so wanted to make sure that we share this. But there's multiple obstacles to rural care, and I'm also very present to the fact that we are preaching to the choir. We're talking to the converted here. So thank you for your interest in learning about this. But I just want to again repeat the points that we all know. This is that we have transportation challenges in rural health. We have time challenges, patients being able to make the time with multiple jobs, childcare, and other opportunities. And then just technology is always a challenge also for patients. My scope is of this part of the presentation is twofold. It's looking at a broader scope of telehealth-enabled care models in rural health. But then also about some tips and tricks around guidance on implementation, kind of what Dr. Mathur here pointed out at. And actually, Dr. Mathur, I'm in just outside of Annapolis, Maryland. So actually, there's a Maryland theme here. And so there's three key multiple challenges for patients, where there's access to care, as I just mentioned, and even just access to the clinical expertise and clinical capacity. And so a service like Equum brings that to the rural hospitals. It's also figuring out then from your leadership perspective, if you're representing in healthcare organizations, what are the best solutions and vendors out there in terms of the services, in terms of the technology. And then the last challenge is, how do I actually adopt innovation, right? Healthcare is traditionally very resistant to change, and rightfully so, because we're dealing with patients' lives here. But that has translated and it has hampered a lot of progress in the last years, as I'll talk about. So, as I mentioned, I am originally from Germany, been focusing on optimizing service delivery for the last 35 years. Stumbled into healthcare 25 years ago, and then started my consulting firm in 2012 with a focus on helping healthcare organizations to get the most value out of digital health innovation. So telehealth-enabled models, there is multiple aspects to look at. There's the inpatient care models in the emergency room, at the bedside, hospital at home, post-discharge monitoring for readmission prevention. Then there's healthcare models in rural health around outpatient care. So you can have video visits to the patients, you can have video visits between different locations, you can do a remote physiological monitoring for readmission prevention, but also for chronic care monitoring. You can integrate secure messaging and digital therapeutics for better care management. So there's really a whole set of telehealth technologies that you can use. And with regards to when you think about a care model, who's actually providing the care? And it could be your clinicians empowered and enabled to reach a broader population or reach your geographically distributed population. With your clinicians, you could have regional virtual clinicians, other academic medical centers that you're connecting with, or you can have clinicians that you engage through services like Equums as your virtual clinicians, the ones that are really kind of part of the overall care team. So so there's a whole set of opportunities here, and the question oftentimes is, how do you get started? And care design, as we know, is going virtual. Here's a forecast from 2021 in that from the 5-year forecast was 19% increase in virtual, and then a 29% increase in 10 years. And then we've talked a lot about, or heard a lot about, of hospital at home, and similarly a large projection here of growth of 9% to 15% over 5 to 10 years. Again, that's 3-4 years old now, that data. And the American Hospital Association did admit, so to speak, because I've been involved in telehealth since 2008, and so these larger associations were not always on board with embracing telehealth, but it's very promising to help maintain and supplement access to health services in vulnerable rural and urban communities. And so really it has been recognized, and then obviously the National Rural Health Association also says that telehealth can represent a crucial bridge to essential services. This is a report that was published just a few months ago, really honing in on the great benefits, cost savings, and all the like. So really now, finally, after 5-6 years past COVID here, we're seeing really the data coming out supporting what we intuitively already knew, those of us who have been in telehealth a little bit longer. So Are rural hospitals better off because of telehealth? So that's the first topic of 3 that I want to cover here. Again, you have different models here that you can look at. You can look at virtual only specialist, hybrid specialist, and in-house hybrid. Hybrid meaning in-person and virtual care. There's the care timing, pre-admission, inpatient, and post-discharge. And then you have all these different specialties that you can bring in: critical care, intensive care, neurology, psychiatry specialties, and rehab care. So in the interest of time, I'm just going to hone in on a few use cases, but obviously on the inpatient side, by the bedside, we can look at critical care and intensive care, tele-ICU. We can look at starting rehab. We can look at obviously bringing in other specialties in, especially in the critical access hospital environment. On the pre-admission side, obviously in the ED, we're all familiar with telestroke, telecrisis, to take care of patients in a timely manner, whether they are suspected of stroke or whether they are in a behavioral health or mental health crisis. And so there's just numerous kind of scenarios that you can look at. Again, what we're always looking at is what is your strategy for the next 3 to 5 years? How do you want to integrate telehealth, telemedicine in your practice, in your hospital, and maybe in your associated rural health clinics? We have a lot of clients out west in Washington State that have a rural health clinic associated with a critical access hospital. And so we're working on both sides there. And so I'm going to skip over the next slides where I was just going to go into the detail here. So what are the pros and cons for telehealth of rural hospitals? So the pros obviously is access to clinical specialties, freer transfers, as Dr. Mathur just demonstrated, and increased census in your beds, which increases your financial viability. You can use it to expand your swing bed programs, which is a lucrative line item on most critical access hospitals' financial models. Keeping the patients local, which allows you to involve the family caregivers for better recovery, and just ability to take care of patients adequately. There's a C missing there. But the cons is that it's not trivial to implement. It's coordination and communication is key. Dr. Mathur had on the last slide here the emphasis on workflows, clinical workflows, which is really what enables these modern services that are technology fueled. Managing the resistance to innovation and to the resistance to outside clinicians, so that is there as well. And how do you finance and find the investments, not just in the infrastructure, but also in the qualified staff? And then some clinical partners may push for transfers. So there's some rumors out there that, right, if you work with an academic medical center, that they want your patients. So I have not found that to be that true, but there's a rumor that was discussed in a LinkedIn discussion last year that where that kind of came up. So so that's kind of rural hospitals, but really let's think beyond video visits as all, right? Telehealth, most of us equate with video visits. And so I want to just start off with that. I've been a long-time observer and student here of the kind of the evolution of the language that we use in healthcare to describe the patient care participation. As any clinician will tell you right away, is that if the patient is engaged and involved in the care, you have a much, much better chance of a great outcome. So the first term that when I entered healthcare in 2000 was compliance, right? Patient had to be compliant. Here's your plan. You had to submit to a wish, request, or demand by the person in the white lab coat with a stethoscope around their neck. And then we said adherence, sticking to a plan. And then really for the last 10, 15 years, I would say really the term that has been used is engagement. So really engaging patients in their care. I think what appeared about 5, 6 years ago, at least on my the radar here, is the term of activation. Is how can we really activate patients, especially when it comes to chronic care management, especially if it comes to recovery after hospital visits. If patients are not activated, if their care surrounding care staff is not really engaged, the family members are not engaged, it is much harder to really have a good recovery or to stay in control of your chronic diseases. And so what I'm always looking at now, putting on my engineering hat, how can we use technology to engage patients more? And so how can we really leverage the various telehealth modalities to facilitate that patient activation, right? How do we really make that? And so just wanted to show you this kind of matrix of 9 different telehealth modalities, which you're all familiar with, and they go from simple to more complex, from left to right, and then synchronous to asynchronous. And obviously, we're all familiar with the audio video televisits, where everybody experienced telephonic care extensively during COVID because video didn't work, especially in the first months for most people. And then we also know we have remote exam capabilities of dermatology cameras, or cameras that look into the throat, or even a digital stethoscope. So that's kind of the video lane here. Then we go a little bit more asynchronous with periodic remote physiological monitoring. That's your scale, your blood pressure. Then there's continuous remote physiological monitoring, some technologies out there in the cardiac and the diabetes realm. And then also the whole realm of patient-generated health data, your Apple Watch and other things that are created. If physicians really had easy access to that, would make a profound change for some patients. Then we have store and forward photos, audio, video, or data. We've used that a long time. Faxing and EKG is telemedicine. It's one way to get remote care, but obviously now we can send pictures, things. Secure testing or secure messaging, I think, is really one of the ways that most patients are going to be able to be activated to participate in their care. And then there's the whole new world of digital therapeutics, being able to prescribe apps to help patients to deal with a chronic disease, with their recovery, with their treatment. So really the world of telehealth is really just very broad. Telehealth, virtual care, telemedicine, whatever you want to call it. And just want to put that out here for consideration as you're thinking about, okay, which of these modalities could we employ in order to help our patients better? And so really there's, and then specifically for rural telehealth, what we've seen and we've been working on is that remote physiological monitoring, secure messaging, teleparamedicine, as well as community access points. And so just a few words on some of those. RPM, again, you activate patients by involving them in seeing their data, getting a call if they're not having a measurement, or getting a call when their numbers are up, and the monitoring nurses activating them, doing post-discharge monitoring to have readmission prevention, and then also shifting patients sooner to the home, again with RPM, but also staff obviously that comes into the home. So those are 3 key use cases that are of great value when it comes to rural health. Here are 6 examples of community access points. We've been engaged by a Medicaid agency in Washington State, and we've implemented school-based, library-based, and fire station-based telehealth. And I've listed some states' initials here where I know that these programs exist, where there's access points to that. There's also a great resource here. Just search for NRTRC, find telehealth. NRTRC is the Northwest Regional Telehealth Resource Center. And they have a map out there where you can access community access points. So I looked at New York here. So there's something down in their region. So probably not a lot of people aware of this resource and have not inputted their data. But that is a resource where then clinics can also point patients to community access points in the regions, how they can set that up to overcome that digital equity piece. So third section here, innovation in healthcare. How do we implement digital health solutions? And so the problem in healthcare as I've identified it, is not the lack of innovation. There's so much great innovation out there, innovative services, innovative technologies, and with AI, it's going to be just accelerated. The problem is the slow pace of innovation adoption. And I think my sloth is coming up here in a minute. Yeah, there we go. So, right. And as I said at the beginning, the intro, right, it's innate to healthcare to be resistant to change, and it's good when it comes to patient care that we don't just willy-nilly prescribe new medications, try out new procedures. But these interventions have been proven to change and improve, and so the resistance is no longer really warranted. And so how, as a leader, can you now overcome that? And so here are the 5 leaderships of transformation that really every healthcare leadership team needs to be good at. It's the innovation leadership, leading change, leading projects, processes, and also improvement. And so I just want to zoom in on a few things here. And again, I'm watching the time and I'm not seeing the chat, but I saw just the chat message come through. So if you have a question, we're happy to leave a few minutes at the end here. But you go from a problem, an idea, you evaluate it and you prioritize it. You got to figure out where do you get started, and then building a strategic, financial, and clinical case. Is this really something that our hospital, our clinic can do? And then applying these things to develop the solutions and then deploying it using change management. So this is a good overview slide of really to go from an idea systematically to something. Then you do a proof of concept to validate it, and then project. I'm just gonna go a little bit forward here. Just want to highlight key concepts. A strategic case is one thing that you need to start with. In terms of aligning it, how is this going to help us to achieve our strategic objectives? You're going to be putting, I assume a lot of you have put together a strategic plan, put a lot of thought into it, and so really telehealth is a way to utilize utilize telehealth to achieve your strategic objects. And so really looking at that. Then next is the business case. What's the financial model? And then again, if you've already have selected a vendor like Equum and others, they can help you to build that business case to make sure that it's financially sustainable. But what's the value? What's the cost? And then last but not least, what's the clinical case? Making sure that this is clinically sound, clinically acceptable. How can it be integrated into the care continuum? And so that you have a continuity of care for your patients when you're integrating, especially external physicians into that. And so then getting to serving the patients. I just want to definitely bring up this one. Don't put the horse behind the cart. I know I'm from Germany and I'm butchering your idiom, but it's what I mean to say. It's so don't select the technology first and then figure out what you want to do. So don't just buy into a telehealth card or an RPM solution, or even before you go out to look for a vendor. Really, it's figuring out first, what is the service that you want to deliver? What are your clinical, operational, financial workflows that you want to have, and then go out and shop for a vendor. Because then when you find a vendor that aligns with your requirements, then you have confidence that this will be successful. If the vendor educates you on what you need, then they will be automatically, with no bad intent, biased towards what they are good at. So you really got to independently develop your own thoughts here. Want to end up with here that there's numerous opportunities out there, as many of you may be aware, and Dr. Mathur also pointed that out, right? Finding grants, finding sources of funding. So obviously these the vendors need to be paid, the consultants need to be paid, you need to pay your staff, you need to buy technology, and so there's numerous programs out here that are being again reach out to Equum here, so they made the slide available to me to integrate into my part. But with that, again, just there's multiple challenges that you have as leaders of healthcare organizations to provide better access to care, figuring out what is the solution, do we do RPM, do we do video to patients' homes, do we integrate? And the answer is yes, but the question is in what order, what is the highest priority, where do you get the biggest bang for your buck? And then building that internal capacity, because you will have to, for the next 10, 15, 20, 25 years, you will have to continuously adopt innovation. Innovation is just going to increase, and new technology, new solutions, new AI is going to be out there to do that. And so if you have a camera at handy and want to have some articles that go along with that, just complete this form here. But with 2 minutes to spare, we had some Q&A here prepared. But Andrea, are there some questions that have come up in the chat that we should be covering here? And I'll just go to our contact slide here.
Yes. Thank you, Dr. Mathur, and thank you, Christian. That was a very informative presentation. We do have one question so far in the chat. I know we only have a couple minutes. So Stephen Kelly is commenting and asking, Your examples show strong published evidence for rural hospitals. Can you share some current examples from your perspective to personalize the story?
Sure, I can feel that one. Thank you. And thank you, Christian. I apologize for going a little over, but your content was great. I love the slide with the cart and the horse. It's so true. But yeah, to answer your question, so the rural virtual dialysis program I shared is part of our portfolio, as well as the virtual cardiology 4-month program slide that I shared. But to speak to a little bit more, we have active clients that are low on specialty access, where we've implemented programs called admission decision support. So in addition to the routine collaborative consultation with the specialist for cardiology, with nephrology, ID, for example, part of that program is looking specifically at those gray zone patients where you're not sure that they're safe to keep clinically, or perhaps there's just a question around their eligibility to retain local. And what we do as part of those programs, and already before they even get implemented, all of that gets discussed. What resources do we have? What's the comfort level, et cetera? But part of those programs, for example, at one of our institutions that doesn't have an ICU, we've been able to keep over 60 to 70% of patients when called for a cardiac consultation for a admission decision support, with very low secondary transfer rates, under 10%. And so I'm happy to connect with you separately to share a little bit more about those programs. But I think that speaks volumes to sort of how we can add value to those really question to admit cases, where I think on average, and we're talking about over 800 cases that our cardiologists have seen over this last 2024, where they, when accepted, have accepted about 60 to 80% of them. In the slide that I shared about the virtual cardiology program that had the 4 months, that translated to 31 patients additionally for that local institution that they were able to keep. There's a lot of conversation of how we can sort of explain some of the program details, but let me know if there's any more specific questions.
Thank you, Dr. Mathur. And I know a lot of people probably have to hop, so feel free, but we'll just take one more question. Also from Stephen Kelly: what metrics should healthcare leaders use to measure the success of inpatient telehealth programs?
Yeah, sure. I'm happy to take that one as well. It really depends on the program, and those KPIs get addressed during the clinical design phase, and maybe even earlier when we look at sort of what program, what problems are we trying to solve for. But some of the common KPIs that we look for is reduced out-of-network transfers, retaining patients locally, like the one I just spoke of, the admission decision support. And then from a patient safety perspective, also looking at, once they're accepted, what is the secondary transfer rate? And then I think on the critical care side, where there is more published evidence around implementation of those programs, we often look at response times. We look at co-management and engagement. So are our providers actively engaged in cases with the notes they're writing or the orders? If we get into more complicated sort of programs, we can put in processes in place to look at Apache data, length of stays, ventilator days, and other things. There's actually no limitation to the KPIs that can be discussed or on the table. It's really about more of the program's capabilities and what's important to the local institution. And then there is variability amongst the different service lines of what they think are important.
Thank you, Dr. Mathur. And thank you, Christian, and to your teams for all the coordination and for the wonderful presentation. Again, this is a recorded session, will be available on AHI's YouTube page and will be sent out with the meeting notes. Again, just a reminder to everyone, the next Telehealth Learning Collaborative is scheduled for Monday, March 24th at 2 p.m. If you are interested in presenting, please reach out to me. And thank you again for your time today. Have a good rest of your day, everyone, and look forward to seeing you all in a couple of months. Take care.
Thank you so much
for organizing. Thanks for having us.